Hello. In this episode, we begin our discussion on conditions associated with noisy breathing. Many of these conditions are important and emergency differential diagnosis of upper airway obstruction manifesting as stridor, but some of them are also associated with wheezing or other respiratory noises such as whooping in the pertussis, whooping cough. I want to draw your attention to the fact that the case presentation of many such patients would be a form of respiratory distress or even cyanosis or the signs and symptoms of respiratory failure or impending respiratory failure as a complication. For that reason, I have dedicated different episodes to the differential diagnosis of respiratory distress syndrome in children which are not secondary to upper airway obstruction. And in a different dedicated episode or series of episodes, I have discussed the differential diagnosis and management of cyanosis in children. Next step is to remember that for the ease of understanding and better categorization of differential diagnosis, I have categorized these conditions into acquired mechanical versus acquired infectious causes, and then the congenital and genetic causes. So the conditions associated with noisy breathing or upper airway obstruction in children have several differential diagnoses, and that is our first question. What are the mechanical causes of upper airway obstruction? Always think of foreign body as well as some sort of mechanical or physical trauma, such as smoke inhalation or such as trauma to the neck causing hematoma, causing airway obstruction. We will discuss them one by one. Now, what are the important infectious causes of upper airway obstruction? We are dealing with conditions that directly involve the airway, and those are epiglottitis, croup or laryngotracheobronchitis, diphtheria, which is not very common anymore, as well as bacterial or infectious tracheitis. Then we have conditions that are associated with some sort of neck soft tissue mass infection impinging on the upper airway, and in that differential we discuss conditions like peritonsillar abscess and Quinsey abscess or retropharyngeal abscess and their complications such as Lemieff syndrome. All of these are discussed in a dedicated episode to neck infections. We include also neck lymphadenitis, Ludwig's angina, and cervicofacial actinomycosis. There is a very important episode. Please check it out. Other than these, we have some conditions that are not necessarily associated with a stridor, or anytime you hear a stridor, it means upper airway obstruction, but could be associated initially with other noisy breathing, such as wheeze, as seen in RSV-induced bronchiolitis or in pertussis. Then at the end of the list, we have these congenital and genetic causes. Of course, cystic fibrosis is one important cause of respiratory complaints in children, and that's why I included it here. But we have some of these congenital abnormalities, such as malasias, tracheomalacia, laryngomalacia. Then we have choanal atresia, could be unilateral and not very symptomatic, but if it's bilateral, could be associated with severe symptoms. And then we have this little differential at the end, the vascular rings that could impinge also on the airways and cause noisy breathing. With that framework in mind, whenever you have a child with noisy breathing, whenever you have child with any sort of upper airway obstruction specifically, these are your not to miss differentials for that scenario. And with that background, let's start our discussion. The focus of this episode is the mechanical causes, beginning with foreign body aspiration or ingestion. What are the symptoms suggestive of a form of foreign body aspiration or ingestion as the underlying etiology of noisy breathing in a child? We have a previously healthy child, most commonly in the age of 1 to 3 years, with sudden initiation of cough and dyspnea, plus possibility of either wheeze or stridor depending on what level of airway obstruction we are dealing with. The physical exam shows decreased breath sounds, breathing sounds locally, not bilaterally usually. And so based on what mainstem bronchus is affected or the branches, that specific location will show decreased breath sounds. Very important question is how complications possible in the course of foreign body aspiration could hint in favor of localization, the location of obstruction. While bilateral obstruction can quickly complicate into life-threatening respiratory compromise, that's a full-blown symptoms of upper airway obstruction and it's an emergency. Lower airway obstruction initially manifests as wheeze that's resistant to short-acting bronchodilator and later on can complicate into localized lobar pneumonia. Localized atelectasis and bronchiectasis are also other complications of foreign body obstruction. Put it simple, based on stridor versus wheeze and the complications we can determine if we are dealing with upper or lower airway obstruction or unilateral versus bilateral. Now, if pneumonia is complication of foreign body aspiration, what is the hallmark of that pneumonia? It's usually resistant to antibiotics, meaning that it's usually recurrent. Now, if you have a patient with these symptom manifestations, what is the next step? The very next step is to figure out if the patient is stable or unstable, or if the patient could maintain a patent airway or not. Now, in addition to failure to demonstrate ability to maintain the airway patency, there are other symptoms that indicate severity of upper airway obstruction, and I have made an acronym for it, and that's PITED. If any of these PITEDs are available, are positive, it means the patient risk is high and we need to consider some intervention to maintain the airway open. What are these indications of severity? P stands for position, especially that neck extension tripod position of epiglottitis or the sniffing position. I in PITED stands for inspiratory stridor or prolonged inspiratory phase. T stands for tongue or oral mucosa swelling as well as trismus, the jaw lock. This may indicate emergent neck infections threatening the patency of the airway. And the final D's are drooling or dysphagia and or any sign of respiratory distress. So if you have a patient with PITED, that's a severe patient, we need to consider intubation. Again, remember, these are other than the general indications for intubation, such as hypoxemia or altered mental status with GCS of 8 or less. On the other side, we may have a case of foreign body aspiration in which the patient is overall asymptomatic and is stable. So these two have different approaches. If we have an unstable patient or a patient whose PITED symptoms are positive, we need to inform the ENT and anesthesiologist for consideration of a procedure to secure the airway. However, if the patient is stable and have no PITED symptoms or otherwise asymptomatic and just we are suspicious of a foreign body aspiration ingestion, next test will be a plain X-ray. Again, remember, this is not the best test and I will explain what, but this is the first test in stable asymptomatic patient to perform a plain chest X-ray. Okay, let's return back to our algorithm of unstable patient or patient with severe obstruction. Always remember that at any point the patient becomes unstable, you need to initiate CPR. However, if the patient just has severe obstruction and you have informed the anesthesiologist or ENT personnel for intervention to secure the airway, before their arrival, you have to some maneuvers on an attempt to exit or expel the foreign body. And that maneuvers depend on the age of the patient. If you are dealing with an infant, you start with back slaps and chest thrust. 5 back slaps followed by 5 chest thrusts, and then you see if it helps. If not, you continue that cycle, considering if the patient becomes unstable, you perform CPR. However, if you are dealing with a patient older than 1 year, you can perform Heimlich maneuver. Now, the question, very important question, is how long we continue these initial emergency attempts. We continue them only for 1 minute. If for 1 minute we have no symptom relief, we need to perform what? Direct laryngoscopy. Remember, it takes usually more than 1 minute for the ENT surgery or anesthesiologist team to be available. So we need to know what is the responsibility in our side. So what is the next step? Direct laryngoscopy is using the McGill forceps to visualize and remove the foreign body. But even in that case, we are faced with 2 possible outcomes. One is the relief of symptoms, and the most important thing we need to check is resumption of adequate spontaneous breathing. If that's the case after direct laryngoscopy, all that patient needs is supportive care. However, remember that it's quite likely that even after laryngoscopic removal of the foreign body, the patient may not resume adequate spontaneous breathing. So what is the next step in that scenario? The patient has breathing, so we are not doing CPR, but the breathing is not adequate, it's labored. What should we do? We give the patient O2 supplementation through bag valve mask. What next? If this patient who received bag valve mask is still in distress, as always, the next step is intubation. So once more, these are extremely important steps to have in mind. Every single step has its very specific place in the algorithm. So if the patient has symptoms of severe obstruction, we inform the surgical team, ENT or anesthesiology, and we initiate the maneuvers, Heimlich or back slap chest thrust. If the patient does not respond within 1 minute, we attempt direct laryngoscopy. If direct laryngoscopy removes the foreign body successfully and the patient has adequate breathing, patient just needs supportive care. But if the patient does not have adequate spontaneous breathing, we initiate breathing support with bag valve mask. If it does not help, still we need to consider the rapid sequence intubation. So if you are asked what is the very next step after successful removal of a foreign body with direct laryngoscopy, next step is O2 sat assessment and assessment of ventilatory support, and seeing if the patient has any residual edema. Presence of edema may indicate the possibility of worsening airway collapse. We are not yet done with the scenario, because the other scenario is, even if we try the direct laryngoscopy, either with spontaneous breathing adequacy or inadequacy, we may not be able to remove the foreign body. So true or false, if the foreign body is not removed and the patient has stridor and signs of upper airway breathing, again, if direct laryngoscopy failed, the next step is rapid sequence intubation. That is false. If direct laryngoscopy fails to remove the foreign body, our invasive method is decided upon based on the location of obstruction. Pay attention that the invasive airway is not endotracheal or nasotracheal intubation, because the foreign body would not let the tube reach the trachea. So depending on whether or not the obstruction is subglottic or supraglottic, we perform cricothyrotomy, or surgical airway will be the option. And by surgical option, I mean tube tracheostomy. Now, how do we differentiate these two? Well, remember that the cricothyrotomy, or also known as cricothyroidotomy, is the approach when the obstruction is above the vocal cord, and this could be known either by the imaging or by the laryngoscopy. But if the foreign body is subglottic, that is under vocal cord, which is the level of cricoid cartilage, that will not help maintain the airway logically, so we need to perform an incision that is underneath the level of cricoid cartilage, and that is the surgical airway. You know the incision location for tube tracheostomy. The surgical airway is under the cricoid cartilage, between the angle of mandible and the cricoid cartilage, and again that means if we are dealing with subglottic stenosis. So please remember these couple approaches. If it is subglottic, we need to accelerate our ENT team for surgical airway tube tracheostomy. If it is supraglottic or above the vocal cord, we attempt cricothyrotomy. Now the question is, what are the contraindications to surgical cricothyrotomy? Because cricothyrotomy could be performed either as a needle cricothyrotomy en route to the surgical airway, or it could be performed as a surgical emergency operation, incisional cricothyrotomy. Remember, if the patient has laryngospasm, or if the patient is a kid younger than 12, the surgical incisional cricothyrotomy would be associated with complications, and we will not attempt it. We will perform needle cricothyrotomy en route to surgical airway for these children or patients with laryngospasm. In other words, these two conditions are the conditions in which the airway would be also subglottic, even though the obstruction is not subglottic. Children and patients with laryngospasm. In children, we attempt, or in both of them, we can attempt needle cricothyrotomy. Remember, tracheostomy is not performed in ED, so it's usually a permanent or elective airway. Also, we perform chest X-ray after these procedures to rule out possible complications such as pneumothorax. Now, what if the patient with suspicious foreign body ingestion or aspiration is stable? If the patient is stable and has no symptoms, the first step will be plain X-ray. Now, what is the challenge of chest X-ray assessment of the foreign body ingestion? Remember, up to 30% of the times there will be no finding, and also many of the foreign bodies ingested are radiolucent and are not detected by chest X-ray. So if the suspicion is high, or if there are other changes in chest X-ray, what's the next step in the stable patient? If everything in chest X-ray is normal, but we still have moderate to high suspicion, we don't go with an invasive method like bronchoscopy. We perform CT, we perform chest CT. Now, if the CT is negative, we observe and follow up the patient in 3 days. But if CT detects foreign body, we go and manage it with rigid bronchoscopy. Now, rigid bronchoscopy would also be the case if chest X-ray detects the foreign body. Also, many centers, depending on how fast the patient may risk deterioration, if there are indications in chest X-ray of foreign body such as hyperinflation, some centers may consider going to bronchoscopy directly, which is the definitive gold standard for both diagnosis and treatment. Remember, in the case of stable patient, we most likely are dealing with something more distal, and that's why the obstruction is not bilateral, causing deterioration. So bronchoscopy, not laryngoscopy, is what's needed. Now, I would like to also include the possibility of foreign body ingestion into the digestive tract in a kid who has the risk, and that's a kid without any respiratory symptoms. We again begin with performing the imaging studies after ruling out the respiratory distress, beginning with the x-rays of neck, chest, and abdomen. For example, lateral neck x-ray, chest x-ray, and upright abdominal x-ray. This is the attempt to localize the foreign object that's being ingested. If the results are unequivocal, we perform CT. Now, the management is dependent on the location and timing of the object. If the object is identified in the lower GI tract, we just discharge the patient and notify the patient about the possible symptoms with one culprit, and that's if we have ruled out the possibility of high-risk objects. That's usually objects that are sharp or more than 24 hours in the lumen, or if the object is a battery. Also, if the object is in upper GI and have any of these high-risk features, we need to perform emergent endoscopy. What's that? Performing emergent endoscopy means performing it within 2 hours. Now, if this object is in the esophagus but does not match the high-risk criteria, that's not more than 24 hours, it's not a battery or sharp object. If it's in esophagus and low risk, we still need to perform very rapid endoscopy, but it is not emergent, it's urgent. It has to be done in 24 hours. But if the object is neither high risk nor in esophagus, but it is still in upper GI, in stomach or duodenal bulb, we follow with expectant management. Remembering that the expectant management would be okay given the fact that these objects usually are safely removed if they have reached the stomach or duodenal bulb or the lower GI. They can even stay there in the follow-up imaging up to 4 weeks. We can wait, and if it's not being expelled, we need to consider some scopic or, if not successful, surgical removal of the object. So this is our approach to the foreign body ingestion or aspiration. The very first thing to consider is if the patient is unstable or has symptoms of severe airway obstruction, with the acronym PITTED, with position, inspiratory stridor, tongue swelling or oral swelling and trismus, respiratory distress, drooling, or dysphagia. If any of these are positive, we need to inform the anesthesiology or ENT team for consideration of interventional airway management, and we initiate the treatment in the emergency department either by performing Heimlich maneuver if the patient is older than 1 year, or performing back slaps and chest thrust for infants. Remember, we do this only up to 1 minute, and if it's not successful, we need to move on to direct laryngoscopy with rigid bronchoscopy. Why don't we use flexible bronchoscopy? Because it only has diagnostic utility. If it is successful and the patient has adequate spontaneous inspiration and respiration afterwards, we provide supportive care. Otherwise, we may consider bag valve mask, or if it's still deteriorating, intubate the patient. If laryngoscopy, bronchoscopy is not successful, depending on the level of obstruction, we either attempt cricothyrotomy for supraglottic obstruction. Remember, needle is the approach for children and those with laryngospasm. Or if it is in the infraglottic, subglottic region, we directly intubate the trachea. We need it to be done on the surgery. It's called surgical tracheostomy. If the patient, however, is stable after foreign body ingestion or aspiration, we perform lateral X-rays, chest X-ray and abdominal X-ray. If we find the foreign body in the airway in the stable patient, the management is rigid bronchoscopy. What are the chest X-rays supportive of this that may obviate the need for CT scan? Hyperinflation, mediastinal shift, possible lobar atelectasis. Now, what chest X-ray findings hint in favor of foreign body aspiration? Again, I repeat this: hyperinflation in the site of obstruction, mediastinal shift away from the site of aspiration, and atelectasis. Atelectasis is distal and usually same side of the obstruction, but if we have hyperinflation and compressing the opposite lung due to mediastinal shift, some degree of opposite lung collapse could also be possible in severe cases. However, remember, mainly we deal with atelectasis, distal and same side of the obstruction. CT is used only if there is high clinical suspicion and chest X-ray does not show anything in asymptomatic patient. If you are dealing with foreign body ingestion in the GI tract, if it is in the lower GI tract, we take an observant management. If it is in the upper GI tract, depending on the location and the risk features such as sharp object or battery or more than 24 hours in the upper GI, we need to perform scopic studies. If any of these 3 high-risk features are present, we perform it emergently within 2 hours. If in the esophagus, we perform it urgently within 24 hours. And if it is in the stomach or duodenal bulb, we manage expectantly, and we may reconsider if the object is not expelled for 4 weeks. So this is our discussion about foreign body aspiration and ingestion.